All right, so hello, Access team. You can see we have a special distinguished guest, Deputy Chief Emily Owens, and she's going to be talking about things that we need to pay attention to on the clinical side. So I'm just going to give it to her, and please pay attention.
All right. Hi, everyone. Today, we just wanted to go through some tools that you could have in your toolkit as you continue to do crisis assessments. There's a lot of information that can be had with collective documentation. So just all the information that you're getting from different sources to then put that in your crisis assessments to then make a final recommendation to that on-call. So we're going to touch upon overview of the crisis assessment. We're going to pull up an example. We're going to talk about how we get information from the consumer, from the referral source, from other collateral sources, as well as screenings. I do want to go with over the screenings that we have in our system that you might find useful. These screenings, except for the Columbia, are not required. However, I want you to know that they're in the system and you can pull these screenings to get more information if you feel like you need to do that during that assessment. We'll then talk about the disposition and safety plan. So that's our agenda. We'll just go straight into it here. I have Essentia pulled up. I have a test client we'll look at today. Let's just pull up the crisis note that I started on this consumer, this test consumer, Tim. Tim is a 45-year-old patient, client, consumer that was referred from the local housing complex in Terre Haute. He lives where he lives. He states the housing manager states they are concerned for his overall safety, and notice he seems to be declining. So our referral source here is the housing complex. That's collateral information, right? They're the referral. They're the ones that are coordinating this assessment. They're stating that they're concerned for the safety. We want to make sure we note that in our assessment. The housing manager at the complex. And if we can get the name, that just helps with gathering all the information. Her name's Myra Jones, so we're going to put that in there. She states that she has seen a decline in his overall functioning over the past few weeks, actually. So again, frequency, how long has this been going on? What are specific examples that the referral source is noticing? He's not showering, his apartment has not been kept, he's not eating, he seems overall sad. They state he is isolating himself. And one of the other residents, Mary, even states that she heard him say he just wants to end it all. So when they approached Tim, he states he just wanted to end it and he feels like a burden. And that's when they felt like he needed to be assessed, and he agreed to come in. So we just want to make sure we capture all of that in the reason for the referral, any statements, quotes that we're hearing from that referral source and from the client. The employer in school, he's not currently working. However, he states that he used to work at Goodwill 2 years ago. You know, even if they're not employed or in school right now, we want to make sure that we capture, if we hear them say that they were employed previously, you know, that's a strength for them that maybe we could use moving forward after we complete our assessment. He lives alone. However, other residents are in the building. Other supports. This is where we tend to maybe not think broadly about other supports. A lot of times those that we assess don't have a lot of supports, but we need to keep our ear if there's a neighbor, a friend, an informal support that we feel would be good for this person to reach out to. So again, the neighbor, Mary, is the one that checks on him frequently. We want to make sure that we put that in our assessment. The PCP, we found out Dr. Smith at Union and Terre Haute, and that the last appointment that he had was 6 months ago. Again, sometimes we're only going to get the PCP as Dr. Smith, but if we can start pulling a little bit more information, okay, well, you do have a PCP identified. When was your last appointment? You know, if it was 3 years ago, that's an issue. 6 months ago, maybe not so much. The presenting problem. Again, we're going to take the information that we got from the housing complex, but we also are going to talk to Tim now. Tim was able to state that he just lacks motivation, problems sleeping, feeling as if he's a burden and just wanting to end it. He does state he does not have an intention or a plan, but he just doesn't know what to do anymore about his depression. He's not sleeping well or eating. And he kind of leaves it at that. He doesn't have any close family, but he does identify Mary as a support. He presents with a flat affect, sad mood, and somewhat disheveled. He lacks direct eye contact with us when we were assessing, yet he did start to engage more throughout the assessment. So again, this presenting problem, what you're hearing from the consumer, what we heard from the complex, what's your take as far as the observation as when you're talking to Tim? How's his mood? What's his affect? The previous psych treatment, again, we want to take as much information here as we can. We know he said, as an adolescent, he had some outpatient because his mother died of suicide. Okay, when they say that they've had past history of services, we want to make sure, okay, well, what was that for? What was going on at the time? He had some counseling for depression at age 20 to 30. He currently states that he was going to start counseling again a few weeks ago, however, didn't come in for the appointment as he just wanted to sleep. We did see in the record. So again, if we see something in the record history, we can use that as collateral information for our assessment. Based on the information from his chart, he did have limited case management services in his previous episode. We want to make sure we note that. And there's been no history with hospitalizations. Moving on to the assessment part, Tim states that he has had some ideation with just wanting to end it. However, he states he doesn't have a plan or intention. We know we're going to do the Columbia, and we can go through that here in a little bit. And there's also a screener that we're going to walk through today called the PHQ-9. Some of you might be familiar with this. Some of you might not. It's a 9-question patient health questionnaire. I find it very useful to use, especially if you're just trying to get more information on how these symptoms are impacting the client's functioning. I use it for all my outpatient clients, and we can use it for the crisis assessments as well. There's no history with homicide ideation. There doesn't seem to be any psychosis. He does state he has high blood pressure and is on medication for this. He even showed you the bottle that he brought in, so you want to make sure you note that if he shows you any of the medication. No other medical issues, no allergies. He's on the blood pressure medicine. He does state he likes to drink beer occasionally and smoke marijuana. He states that there's no issues with this, however. So, he kind of stopped there. He didn't want to go into more detail about that. So I might want to do an ASI, an addiction severity index screen here in a few minutes to see if there's any other substances, what's the frequency, how long has he been using. We'll go through that here in a minute. There's no legal issues. And then our assessment. I'm going to leave this screen right now. We're going to come back to the assessment and disposition. So after I get some information from Tim, I feel I want to go and do a screening to gather more information. I'm going to come to the left-hand screen, the side of the Essentia portal, and I'm going to come to the behavioral health screenings. In this portal, you're going to see the GAD-7, the PHQ-9. The GAD-7 is a generalized anxiety scale. It's a 7-question. We can open that up. Begin screening. Now, this is if you feel like you want to gather more information about their anxious symptoms or if you see some anxiety going on. And you want to ask over the last 2 weeks. So this is a very specific screen that they need to answer within the last 2 weeks. Have they been bothered by any of the following problems? Are they feeling nervous, anxious, or on edge? This one is not at all, several days, more than half of the days of that 2-week period, or nearly every day, okay? So again, this screen is very direct. You just want to know, have you been feeling nervous, anxious, or on edge? And you ask them, has it been not at all, several days, more than half, or nearly every day? So Tim, he said several, not being able to control worry, Oh, not really at all. Worrying too much about different things, not at all. Is he having trouble relaxing? Several days. Being so restless that it's hard to sit still? More than half. Becoming easily annoyed or irritable? Not at all. Feeling afraid as if something might happen? Several. And that's it. It's a 7-question. And then you go to your actions and you complete that master assessment. He scored a 5 out of 21, I believe it is. So it's rather a low score. So it doesn't seem like he's having a lot of anxiety. This is the generalized anxiety screen. The patient health questionnaire is more of their mood. So if you start this screen, it's going to ask you again, over the last 2 weeks, how often have you been bothered by any of the following? Little interest or pleasure in doing things. Well, Tim, it's nearly every day. He's lacking this motivation. Trouble falling asleep or staying asleep too much. Is it nearly every day, more than half, several, not at all? For him, it's more than half. Feeling tired or having little energy. Well, it's almost every day at this point. Is he feeling bad about himself or feeling that he's a failure or that he's let himself down? More than half. And you can also write additional comments, obviously, in this area if you need to. Is he moving or speaking so slowly that other people would have noticed, or is he being so fidgety and restless? For him, it's not at all. And then this one, thoughts that he would be better off dead or hurting himself in some way. So he says he is having thoughts. However, he states no intention or plan. So, and he's saying it's several days. If they checked any of these problems, how difficult has it been for Tim to take care of things at home or to get along with other people? And he said it's somewhat difficult. And that's the PHQ. When you're done with that, you complete an update master. And it looks like Tim scored an 11. So he's right in the middle range of mild to moderate. Well, it would be moderate going to severe depression based on this score. And we'll see on the document, it will give you that range. So that's the GAD and that's the PHQ. He also said something about the substances, the alcohol, the marijuana. So I feel like I need more information on that. I'm going to go to the substance use disorder screenings here on the left-hand side, and I'm going to open up the ASA Lite, the Addiction Severity Index. We also have the audit, which is the alcohol use disorder treatment screen. And we also have the DAST, which is the drug abuse screen, 10 questions.
That's a bonus. If you know what audit is, bonus.
Yes. So I feel like I need to do the ASI. I want to get more information on his substance because he seemed to be very closed lip about that. So I'm going to ask him these questions. Have you ever or are you currently using alcohol or drugs? He is. And then I'm going to ask, okay, and it goes substance by substance. So it's a more direct way on how we can get this information from some of our consumers. In the past 30 days, how many days have you used alcohol, if any? He says 8. In your lifetime, how many years would you have used alcohol? He's 45. He started drinking at 15, so 30 years. How have you most commonly used alcohol? Well, mostly this is going to be oral. So you just go through these questions. In the past 30 days, how many days have you used alcohol to intoxication? He states 4. So you're going to put 4. How have you mostly consumed or commonly used alcohol to intoxication? Again, typically oral. And then it goes into the other substances. He states he doesn't ever use heroin, so you're just going to put a 0 and then never used. And then it goes on to methadone. He's never used methadone. And then opiates, never used. Never used barbiturates. And he doesn't use sedatives or tranquilizers. Never used cocaine. And he has never used amphetamines. Now, he did mention the marijuana use. So this is where you would say, okay, well, in the past 30 days, Tim, how many days have you used marijuana or cannabis? And he says 15. You know, I smoke about 15 days out of the month. So in your lifetime, Tim, how many years would you have used cannabis? Again, he states he started smoking weed at age 15. He's 45. So he's been sporadically using for 30 years. How have you most commonly used cannabis? Again, typically it's smoking. And then in the past 30 days, how many days would you have used hallucinogens? He says 0. And then inhalants, he doesn't use. The last couple of questions, it's in the past 30 days. How many days would you have used more than one substance per day? So he's a drinker and a smoker. So he says about 8 times a month he's smoking and drinking. So you would put 8. And then in the lifetime, again, he has said about 20 years he's done both at the same time. And that's the ASI light. Again, it gives you more information if you're having trouble gathering information, or if you just feel like you need to ask more direct questions about their substance use, how to pull that information out. And you would go and just complete the master. And then this will then be loaded onto that document. So you have a good sense of the history of substance, the frequency, how long have they been using, how often are they using per week, per month. It can help you with your assessment to know that risk. The audit is another one we can go through. Again, this is the alcohol use. This one is a very short one. And this will help us if we are recommending outpatient services, possibly, maybe addictions services or treatment. It's just asking how often you have a drink containing alcohol. Is it never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 or more times a week? He's saying 2 to 3 times a week. And then how many standard drinks containing alcohol do you have on a typical day? And he says 3 or 4. And then how often have you had 6 or more drinks on a single occasion in the last year? And he says about monthly. And then you can go to actions and score. And it's a 6.
I have a question.
So it, yes, Art.
Yes. So, with these assessments, they may be new, to some of our therapists and nurses. What's the best way if they just want to become familiar? Can they log in like under a certain profile?
Yeah.
Maybe talk.
Yeah.
Because that's what I was thinking as you were just going over some of it.
Yeah. So if you wanted to practice some of these screenings, you could just open up this test client in Essentia and just start working on this. These test clients, this number right here is one that nothing will get submitted, or it's just a test. So we have providers go in and be able to get more acquainted, I guess, with assessment and screenings and note writing.
And you can do that under your regular login, so you don't have
Correct.
to. So it's just your regular login, and you just look up kind of like test. Okay.
Yeah.
Yep.
So that's the audit. The DAST is another one, the drug abuse screen. This one has to do more with how is their drug use, substance use affecting their functioning. So, for example, And then some of these first questions are just about their diagnosis, so you might not know yet when they come to access, but we can just go through some of this. So no, no, no. And then it starts with, have you used drugs other than those required? So yes, he has alcohol and marijuana. Do you use more? Yes, he drinks and smokes. Are you able to stop when you want to? He says he is. Do you have blackouts or flashbacks, or have you had? And he did say yes, he has had blackouts to alcohol, so you would do yes. Do you ever feel bad or guilty? No. So this kind of just hones in more about their functioning level with the substance use. And is it really affecting their functioning on a day-to-day? Does your spouse or parent or significant other ever complain about your use? No, because he lives alone. He didn't feel like he neglected family because of his use. He doesn't engage in illegal activities because of it. And he says he never has experienced withdrawal. He does not feel like he's had any medical problems as a result. And so that's the DAST. And so you would just come back up here, complete, and he's scored a 3. So that's a low score. You know, he uses, but it's not really impacting his functioning to the point where it might some others. So we went through the GAD. Again, just a reminder, the GAD is under the behavioral health screenings here. It's the generalized anxiety scale. It's a 7-question. The PHQ-9 is the patient health questionnaire, 9 questions. I use the PHQ-9 a lot, even when I do crisis assessments, just to see how they are rating themselves. You know, is it a daily concern, or is it more than half, or not at all? It gives you a good picture of how that issue that they're presenting with is affecting their daily life.
So if we have staff that have not been using it, you feel that this is something to recommend for them to get familiar with and start using it?
I do, and I do. It's not a mandatory right now for crisis assessments. Right. It's not mandatory. Yep. Maybe one day it will be.
Right.
But the PHQ-9 and the GAD, and really the Columbia, even all of these, they're standardized screenings. So that means that they've been researched, and it's kind of a standard within our field that you pull these screenings in when you feel like you need to get that information that you might need for a thorough assessment. Right. Does that make sense?
Yeah, and just a little comment, all that information from those assessments can be shared when they're staffing with
Absolutely.
a physician.
Yes.
And that gives that physician more information to make a decision.
Correct.
And you know, of all those, I definitely think the Columbia is required in crisis.
Absolutely. Yeah. Yes. So the Columbia is underneath the trauma and suicide screen, and you all should be familiar with the Columbia. This is here, and again, it's one of those where you're going to ask specifically about their, suicidal ideation, the date that it was completed. So Tim wishes to be not here anymore, although he doesn't have an intent or plan. He still endorses kind of that thought. So I would put a yes on that. And I would say, he has thoughts.
Emily, while you're typing that, I just want to mention, because we've talked about this recently, that access is such a high acute area and high risk area that that is the expectation that the Columbia is completed.
Yes.
Either for child or adult, right, Emily?
Yes, it is. Yeah, okay. The Columbia is one that is, for every crisis assessment, we should be doing the Columbia. just to have that information as far as their suicide history and current ideation.
And whether they're endorsing it or not?
Yes.
Okay, all right. I just want to reiterate that to everybody.
Yeah, the Columbia is definitely the one that we want to have. The other ones, the GAD, the PHQ-9, the ASI, are the ones that it's not mandatory, but they're tools that you can pull in if you just need to get that information. You know, if that consumer's not sharing a lot, it's a more direct screen to get the information that you need. And again, the Columbia, you would just go through general, non-specific thoughts. Now with Tim, he's saying that he has no intent, but he's having that general thought of just not wanting to be around. So I would here put thought so he says that he doesn't intend to, he has no plan, but still there's that thought of just not wanting to be here. So you just note that. And you can, use the quotes, whatever he's saying or she is saying, you would put that.
Well, that's a really good point, because then again, you can take those quotes and share them with the on-call.
Right. Yes. Now, on this one, active suicide ideation with any methods not planned without intent to act. So endorses thoughts of suicide and has thought of at least one method. No, he hasn't. And he has no intent. He has stated that. And you can ask this, okay, well, have you thought about how you would do it or intention of doing it? You just go through the questions. Active suicide ideation, thoughts of killing oneself with details. No, he has no detailed plan. He has no firearms at the house. So it's a no. And then you would just continue with the intensity. So this intensity, I would actually have to, I don't know why it's not a, there's not a prompt on here, is there? It's a 1. I'd have to go back and look at that, guys, to make sure I scored that right. For the 1 versus the 5. So sorry about that. And then you just continue, description of most severe ideation. It's just past, not wanting to be here. That's what he keeps on saying. And he has these, it's just been about, 2 to 3 times a week that he's thinking like this, not every day. It's just kind of sporadic the past couple weeks. It's fleeting for him. Just he just thinks about it, and then he can kind of distract himself. Right. And then there hasn't been anything or anyone that has stopped him from this, so that doesn't apply to him. He hasn't had no actual attempts, but if he had, you would get this information here and, put the comments in, the actual attempt, when was it, how many total number of suicide attempts has he had? For Tim, he hasn't had any, but again, how many has he had in his lifetime? You want to ask that. If he doesn't engage in self-injurious behavior like cutting or punching or anything like that. He has had no interrupted attempt as well, but if you were doing an assessment, you want to make sure that you would ask, okay, how many times have you actually been interrupted by a person or an outside circumstance that stopped you from doing it, and get that information. And then the number. And then aborted attempt. So how many times has this person taken steps toward making an attempt but stops themselves before they actually engaged in the destructive behavior? So it's similar to interrupted, except it's that person stopping themselves. Maybe they had the gun to their head, but then they thought, oh no, my kids, and they put the gun down. That's an aborted. And then preparation, it can be anything regarding verbalization of wanting to hurt themselves, taking their own life, assembling, buying the pills, purchasing the gun, like prepping, writing a note. Tim hasn't done any of this. And then, is this person suicidal during the assessment? Tim is not. But of course, if he was saying, yes, I want to kill myself, I'm going to go do that, after this assessment, or, you would put obviously yes. And so you would then answer these next lethality sections if it's actual attempts. So I don't need to do that for Tim, but you would continue to do that.
Okay.
Okay. So you would complete that when you're done. The ACE is something I probably would not recommend. I wouldn't recommend the ACE for a crisis. The ACE is going to be your adverse childhood experiences, your 10 questions as far as trauma. In a crisis, we're really not addressing the trauma that this person has. We're addressing stabilization of the crisis. The ACE can be done on the outpatient level if there's trauma indicated, to know how we want to start with that treatment. So those are the screenings that we wanted to go over today. So to review, we have the Columbia, we have the GAD, the PHQ. I do want to point out that if you're seeing adolescents, the PHQ-A would be that screen that you would want to use versus PHQ-9. It's just worded a little bit differently. Again, it's the past 2 weeks, and it goes down about all these indicators. I think there was one question that's a little bit different.
Is there an age cutoff? Or
usually it's like 12.
12?
Yeah,
Gotcha.
about 12 to 18.
Okay.
You can use PHQ-A.
All right.
Yeah. You can use the GAD-7 as well, if you feel like you want to gather more information about that anxiety.
All right.
I guess they're similar questions, just a different document. So that's there. And then of course the substance use screenings, the ASI, I always have trouble saying that, addiction severity index. That's going to give you all those different substances to see if they're using, and then how long. The audit is that alcohol use, and the DAST is the drug abuse. So how is that substance use affecting their daily life? And so those are the screenings that we wanted to go through today. I'm going to go back to the clinical record and pull up the note. So again, sometimes I'm in this note and I'll just stop, go to a screening and start asking those screening questions if I feel like I need to just jump over. So you can do that as well. So our assessment. We've done a few screenings, we've gotten information from the referral source, we've gotten information from Tim, we've gotten information from the client record from his last episode. So we're pulling all of this collateral, collective information together in our assessment. So he's a 49-year-old Caucasian male that presented in crisis at the center due to the housing complex concern for his safety. He has agreed to be assessed. Provider was able to complete the Columbia suicide screen, which showed no current suicide plan or intent. Provider was also completed the PHQ-9 screen to gather more information on functioning and substance use. The score was, and so you want to make sure you note that. That would be good for the on-call person to know, okay, what was that PHQ-9 if you did that screen, what was that score? So you can go back, and that score, let me see, I don't remember, it was an 11. So you can put that in there. Oh, I have to edit here, don't I? 11. The ASI screen showed chronic substance use, alcohol, marijuana. However, Tim states he does not feel this is an issue at this point in time. So remember, the ASI showed that yes, there was chronic alcohol and marijuana use, but at this point in time, it's really not impacting his functioning on a daily level, and he doesn't really want to address it. So there's not a lot that we can do there. We might use, if he gets linked up with outpatient services, we might use some motivational interviewing and some brief intervention to kind of delve into that substance use more. But at this point in time, it's not a huge risk or concern. Tim has a sporadic history with treatment, mainly for depression, is not on any medications for the depression for several years. He does have that high blood pressure medication, 10X. So again, just taking all the information, summarizing it in this assessment portion. He states he drinks occasionally and smokes marijuana, however, states this is not an issue for him. Tim states during the assessment that he just feels like a burden and is not sure how to get out of his rut. He says it's a rut. So he quotation marks. He states he has no intention or plan to hurt himself. He did ask if he could be referred for counseling again, as well as seen about medications for his depression. So it sounds like he does want some assistance. He's open to services. So your disposition is, after consulting with the NP, Tiffany, and updating her of the assessment and screenings, as well as the support that Tim has at the housing complex and Mary, and his willingness to follow up on outpatient services. It's recommended he see Joe McMahon. We see there's an opening Friday at 10. We put him in there, and then also a referral for medication evaluation will be completed, and a safety plan was completed with him. Tim agreed to this plan and got an appointment card and copy of the safety plan. So your disposition is not only, consulted with NP, outpatient services recommended, it's as specific as you can get it to show that coordination. And that you went over a safety plan, he got a copy, he's going to be seeing the actual Joe McMahon, the therapist, on this day, if we can get that. I know sometimes we can't always have that, but if we can, we should make sure it's in our disposition. That's only going to help have the client understand what the next step is, but then also our record is going to be most up to date on what our recommendation was, especially if it's not hospitalization. We want to see that coordination. What are we doing after this assessment?
One thing that we talked about, I think it was on Tuesday, we were talking about on one of the runs we went on, and how we really can get that much out of the teenager that we were dealing with.
Correct.
And could you maybe just review what your guidance and feedback to us on that was, and how it just kind of relates to this process that we're talking about?
Absolutely. So yeah, I've worked with adolescents for years, and sometimes they just don't want to talk to you.
That's right.
Don't take it personal, but they just don't want to say a lot. So you always refer back to the parent, and you get as much information as you can on this crisis assessment from the parent. If the adolescent doesn't want to say, what school they go to or what their issue is, a lot of it is what the parent is telling you, and you would just put that all in all of these sections. Okay, when was the last, has the child ever been in treatment? Yeah, they were, here and there. You just put all of that in there, and you can put per parent report, that you're getting this information from the parent, maybe not the child.
Yeah, so when that happens, because it's going to happen, we can't use that as a barrier to getting the information that we need.
Right, that's correct. You can't just say, oh, well, the child didn't speak to me. Well, we have to then defer to the parent. Typically, the parent is the guardian, so it's okay if we get a lot of the information from the guardian, especially if they're younger. We're going to be deferring to the parent a lot with this. Now, if they're older, we do want to get as much information as we can from that adolescent. But again, they might be defiant and not really wanting to talk to you. So you would just get as much information as you can from the parent. You would then also utilize anything that the teacher or the school is saying if it's a school referral. So why is that kid being seen? What did the school hear? What did they see? What are their concerns? Put all of that in that referral source, and then the main reason for referral. Even on the referral forms, it will say what the concern is. You can just verbatim put that in the main reason for referral on what the school said.
That helps a lot, because we just want to be ready, because it seems like we're getting more and more calls, and so we're going to be dealing with more and more adolescents. So.
Yeah, there's going to be more adolescents definitely coming through with school now back 4 days a week here in Vigo County. We saw a dip during this virtual time, but we will be seeing more kids between now through May that they will be referring. So that's, very good information to have.
And then could you just emphasize again the importance of the disposition and the level of specificity that you want in there?
And the disposition, again, we just want to be as specific as we can. We know not always are we going to know that this person can get in, next week at 10 o'clock with Joe or with whoever, but we need to try. We need to, if that's the end result is for them to follow up with outpatient, let's try to get them on that schedule. Let's try to reach out. If it's to make a referral, let's note that. That just shows overall good care coordination. And then it's not then left on that consumer to figure it out. They have it. They know, oh, he said that I'm going to follow up. There might be there will be a referral for medication. I have my safety plan. It's good care. That's important, especially if it's obviously not a hospitalization. For hospitalization, you would say, that they're going to be admitted to maybe Hamilton Center inpatient unit due to their risk. Inpatient unit will then follow up, from there. But especially if it's not inpatient, you just want to know what the next step is for this consumer.
And then another thing that we've been working through, and so just so everyone knows, when we do our mobile crisis runs, every Tuesday we debrief on those with Emily as part of it. She gives us feedback on it. And so the most recent round, we had a number of place of service areas that were not done correctly. And could you just emphasize just how important it is on any mobile crisis unit run, and just kind of reviewing that so people just are clear on how important?
Sure, yeah. So the mobile crisis, anytime that we are initiating that crisis assessment through mobile, that place of service will always be, let's pull it down here, the place of service when we are on that main page on the confirmation screen will be mobile, the mobile unit.
Yes,
I think is what it's called.
mobile.
Yeah, mobile. So this is a way for us to track how many mobile crisis runs we have done to then be able to enroll these folks in the grant. So really, if it initiates as a mobile, if we were sending 2-step out on a mobile, that will always be a mobile crisis place of service. Even if we bring them back to the center to be assessed more, it's always going to be that mobile.
And you will hear, she said always, like over and over. It's just always.
That's where it initiated, so that's where we're going to put the place of service.
That's right. Yeah. Did you have anything else?
I think the other last thing before we wrap up is just the safety plan. In this disposition, I said I did a safety plan. Well, I better have done it.
Yeah.
I said did it here. The safety plan, I need to make sure that was done. So for Tim, I did do a safety plan because we're not going to hospitalize. Tiffany, the NP, said, yep, safety plan. give him, you know, those resources. So for Tim, his triggers, it was thinking about his mother's suicide. He finally said, you know, I start to get more depressed when I think about my mother's suicide. You know, just not having anyone to talk to, feeling like I'm useless and a burden. So those are his 3 main triggers and warning signs. That's on his safety plan then. What was his internal coping strategies? He said that he likes to read mystery novels. So, you know, that helps him distract. So we're going to put that on his plan. Watching baseball games on television, talking to his neighbor Mary. You know, those are his coping strategies that he was able to identify. Social situations and activities that helps him. He likes going to visit with the neighbor and other friends in the complex. He likes watching television and listening to music. Those are his things. So that's what we put on his safety plan. I know sometimes it's hard to get this information from our consumers, but we have to try our best just to pull it out. If you hear something in the assessment that was a strength that you can identify, oh, that could go on the safety plan, then make that connection. Mary Smith, Myra Jones, the complex housing manager, and John and Uncle, those are the people that he identified that he typically calls upon when he's struggling. So we're going to put that on the plan. We're going to put the numbers on. If he doesn't know the number, you know, sometimes I'll put, maybe I won't have the number, but it's saved in his phone. So I'll just put it's saved in his phone, you know, so just so that that's on the plan. You know, we don't want to leave any of these text boxes blank, if at all possible.
All right. Well, we thank you, Emily. We know you are a very busy person, so every minute we really value. At the end of these videos, we have like action items. So here are the 3. So number 1, I want you all to summarize what Emily said about dispositions and why they are important. Number 2, we talked about the CCBHC place of service, mobile crisis. Tell us what that is. And then the third one, find 3 of those acronyms and tell us what they stand for. So we'll see how you do on that. One of them was audit. I hope someone gets that one. I hope someone gets it. But thank you very much.
Thank you.
All right.